Welcome to Caring for Patients with Nasal Polyps in 2023, When to Consider a Biologic or Surgery, presented by the Global Education Group in collaboration with the Asthma and Allergy Foundation of America and broadcast simultaneously in Immunology Live and Res Insights Live. This is the second module in this four-part series and is titled CRSwNP and its Comorbidities, an even higher burden on patients. My name is Dr. Stella Lee, and I'm the director of the Brigham Sinus Center at Brigham and Women's Hospital. Today's session is interactive, allowing us to take your questions in real time throughout this presentation. We encourage you to enter questions at any time in the box below. I'd now like to introduce my co-presenter, Dr. Katie Buchheit, Associate Physician at Brigham Women's Hospital and Assistant Professor at Harvard Medical School. Thank you, Katie, for joining me today. Let's get started.
Great to be here.
These are our disclosures. These are our learning objectives for the series. We will summarize the burden of disease and treatment for patients with nasal polyps with the focus on outcomes that matter most to patients, such as the ability to smell, sleep, and be productive. Describe the type 2 inflammatory relationships between nasal polyps and common comorbidities such as asthma and aspirin sensitivity, AERD, or NSAID hypersensitivity, or NERD. Explain how enhanced knowledge of nasal polyp endotypes and type 2 inflammatory pathways can guide treatment decisions. And finally, review recent recommendations for the management of nasal polyps with surgery and/or monoclonal antibody therapy, especially as they apply to the management of uncontrolled severe nasal polyps. So in this module, we will be discussing CRSwNP and its comorbidities, how these comorbidities impact our patients. As you can see here, there are several conditions that occur with patients with CRSwNP. And asthma is one of the biggest comorbidities that we think about, but also we need to also consider AERD, or aspirin sensitivity, allergic rhinitis. Patients may also have comorbid atopic dermatitis, although that is less common. And finally, bronchiectasis, which we'll discuss further. This is an interesting study in a patient's cohort with asthma. And as you can see here, the patients who had severe asthma had higher nasal polyp diagnosis. Patients also had a diagnosis of allergic rhinitis, which appeared similar between the patients who had severe asthma or mild to moderate asthma, and the differences to patients who had healthy controls. The patients who had severe asthma also had worse SNOT-20 scores, as you can see here, 15 in the mild to moderate asthma group compared to 31.8 in the severe asthma group. We know that patients with CRSwNP and comorbidities have more severe disease. And on the left-hand side, you can see the green bar are patients with just CRSwNP. The blue are patients who have comorbid asthma, and the red are patients who have comorbid AERD. And the patients with asthma and AERD have significantly increased radiographic severity scores, as you can see on the left-hand side. And then as we go to the right, patients also with the comorbidities have increased number of sinus surgeries. And finally, patients with asthma and AERD are oral steroid dependent at times. And this is much more pronounced, as you can see here, in the patients who have aspirin sensitivity. Now I'm going to turn this over to Dr. Katie Buchheit, who is an author on this study, and she will talk about the correlation between sinus symptom severity and asthma morbidity in patients with AERD.
Thanks, Stella. So this is a study that was run out of the AERD Center at our institution, led by one of my colleagues, Dr. Bergmark. And what we did was look at actually correlation between sinonasal symptoms tested via the SNOT-22 score and asthma symptoms, which we looked at the asthma control score specifically, or lung function, here shown as the FEV1%. And we see that in actually over 1,000 patients with AERD who have many data points here, that the SNOT-22 score is a significant predictor for both the ACT score and the FEV1%, showing that poorly controlled sinonasal symptoms really is very strongly associated with poorly controlled asthma symptoms. So the two go hand in hand. And there is certainly, I think, a very strong hypothesis that there is a unified airway, that inflammation in the upper airway is really very much related to inflammation that we're seeing in the lower airway in these patients. So I'll hand it back over to you, Stella, to talk a little bit more about recurrence in our patients.
Yeah, great. This is another really interesting study. As you can see, it looks like a Kaplan-Meier curve, but it kind of was that. It shows that patients who do not have asthma on the top black line, and then as you go further and further to the right, this is actual amount of patients who then develop, who have polyp-free, what we would call survival, but it's survival percentage. But you can see here that the patients in the dotted line, in the middle line, are patients who have comorbid asthma, and the furthest line down are the patients who have aspirin-sensitive asthma. And it's interesting to see that patients who have comorbid asthma have about a 1.7 times higher risk of recurrence versus patients without asthma. And then if you look at patients with aspirin sensitivity, you can see that they have approximately three times higher risk of recurrence versus patients without asthma. And in this paper by PJ Wormald's group, they discussed that perhaps in those patients who have more severe disease assessed by comorbidities, that they might warrant a more, not to say aggressive, but perhaps a more targeted approach that is conscientious about the recurrence of polyps and hopefully counsel patients appropriately. We know that asthma adds to the burden of CRS with NP, and as Dr. Buchheit mentioned, it's a two-way street. Patients with CRS with nasal polyps and asthma have more severe nasal blockage. They have more severe smell dysfunction. And also, you can see they have worse asthma control, lung function, worse health-related quality of life, higher associated healthcare costs compared to those who only have polyps without asthma. Patients who have CRS with NP and asthma who undergo sinus surgery have a greater risk of polyp recurrence, as I mentioned, revision surgeries, which really want to try to avoid, and have a higher dependence on systemic corticosteroids, as we discussed in the prior schematic. And patients with CRS with NP and comorbid asthma are also more likely to experience increased asthma exacerbations. This is another way to look at another study that corroborates what we've been talking about. And you can see on the left-hand side, patients with nasal polyps with and without asthma, that the patients who have asthma have higher rates of recurrence. And similarly, if you look on the right-hand side, the patients who have aspirin sensitivity, the patients who have aspirin sensitivity do worse over time, and they do recur more quickly and have more severe disease. So I'm going to turn this back over to Dr. Buchheit, who can talk a little bit more about the clinical characteristics of these patients, especially in the context of asthma and allergic rhinitis.
Great. Thank you so much, Stella. So this slide shows data from actually a really large retrospective study that was done out of Northwestern, where they looked at clinical differences in patients with chronic rhinosinusitis without nasal polyps, so that's the CRSwNP, and compared them to almost 900 patients who had chronic rhinosinusitis with nasal polyps. And we see that there, is a really significantly higher percentage of patients who have polyps also have comorbid asthma, comorbid allergic rhinitis, and are more likely to need more surgeries than the patients with chronic rhinosinusitis without nasal polyps. So, these are certainly diseases that share a lot of symptom overlap and a lot of treatment overlap, but there are distinct clinical differences in the patients as well. Next, this is a look at actually data from the Italian Severe Asthma Network. And they have actually almost 700 patients included in this study. And we see that patients who have severe asthma and chronic rhinosinusitis with nasal polyps, so the light blue bars, have more frequent asthma exacerbations, which is a really important asthma outcome that we care about, they're much more likely to need to be on chronic long-term oral corticosteroids. So they need more steroid bursts, and also they're much more likely to be on steroids frequently. So we know that together, having comorbid nasal polyposis and asthma, this really portends worse prognosis and more severe disease. This work is from an observational study that included, I think, almost 900 patients looking at comorbid type 2 atopic disorders. So they looked at patients with moderate to severe asthma, moderate to severe chronic rhinosinusitis with nasal polyps, and moderate to severe atopic dermatitis to see what other T2 comorbidities existed. And you can see in the moderate to severe CRS with nasal polyps, which is the middle set of columns in each of the three graphs, that patients with nasal polyposis are likely to have comorbid asthma and comorbid allergic rhinitis. They also much less frequently have comorbid atopic dermatitis, but this is something that does certainly occur with nasal polyposis. And, in a future module, we're going to talk more about treatment, but really considering patient comorbidities is very important in selecting an appropriate treatment regimen for our patients with nasal polyposis. So we really like being aware of what the patient's additional comorbidities are and thinking about how we can treat the whole patient and all of their T2 comorbidities together. Another important comorbidity that we see in patients with chronic rhinosinusitis with nasal polyps is non-cystic fibrosis bronchiectasis. So this is work that is from a case control study from a very large electronic database of actually thousands of patients, where they identify patients with non-cystic fibrosis bronchiectasis and those who do not have bronchiectasis. And actually, we're able to determine that having chronic rhinosinusitis with or without nasal polyps is something that can precede development of non-cystic fibrosis bronchiectasis and is really thought to be a risk factor for non-cystic fibrosis bronchiectasis. In a smaller study that we did, just looking at patients who have aspirin-exacerbated respiratory disease, we had a nested case control study where we had 92 patients with AERD who did not have any CT scan evidence of bronchiectasis and compared them to 57 patients with AERD who had CT scan evidence of bronchiectasis. And we see that bronchiectasis is associated with worse lung function in our patients with AERD, a longer duration of AERD, suggesting perhaps that the longer you have AERD, the more likely you're going to have risk for developing this comorbidity. And we also found some other interesting differences in the two groups in the controls versus the bronchiectasis group, which is that the bronchiectasis group was more likely to have comorbid ABPA as well as mycobacterial infections. So, this is something that can lead to a lot of morbidity related to chronic rhinosinusitis with nasal polyps and AERD, and should be considered in patients who have really severe lower respiratory symptoms and frequent infections. So to summarize this module, comorbidities we commonly see in patients with chronic rhinosinusitis with nasal polyp include asthma, aspirin sensitivity or aspirin-exacerbated respiratory disease, allergic rhinitis, and bronchiectasis. Patients who have chronic rhinosinusitis with nasal polyps and comorbid asthma and or AERD really have more severe sinonasal disease. They're more likely to need oral corticosteroids, and on average, they often need a greater number of endoscopic sinus surgeries. And that's in large part because they're at higher risk of nasal polyp recurrence after having a sinus surgery. And bronchiectasis is a common comorbidity in patients with chronic rhinosinusitis with nasal polyps. It really should be considered in patients who have frequent productive coughs and frequent lower respiratory tract infections. So, Stella, I will hand it back over to you to moderate the questions for this module.
Great, thank you so much. I'm seeing a couple of questions. One of them I think would be perfect for you. How do you actually diagnose AERD, and when would you think it's appropriate to do an aspirin challenge?
Yeah, that's a really excellent and important question. So often a diagnosis of AERD can be made just based on the patient's clinical history. So in a patient who has adult onset asthma, chronic rhinosinusitis with nasal polyps, and respiratory reactions to COX-1 inhibitors, such as aspirin, ibuprofen, naproxen, you can, based on clinical history alone, when it's convincing, make the diagnosis of AERD. There are situations where it may not be clear that the patient has AERD. For example, in patients who do not take aspirin or NSAIDs frequently, you may not know if they're sensitive to aspirin or NSAIDs. It also can be obscured in patients who are on a leukotriene blocker, something like montelukast or Xyluten, that can actually blunt respiratory reactions to aspirin or NSAIDs. So in patients that meet those criteria, we will actually bring them into our office and do a physician-observed aspirin challenge to prove that they have a diagnosis of AERD. And I think, for anyone who is suspecting it in a patient and it's not confirmed, it's appropriate really to refer them to an allergist for an aspirin challenge. That is the gold standard for diagnosis, but not necessary for a patient with a convincing clinical history.
Great, thank you so much. There's a question about, are there any markers or other specific patient characteristics that can help predict likelihood of more aggressive, more likely to recur nasal polyps? And I think we went over that in our module, but just to go over some specifics about that, definitely asking our patients about their comorbidities. And one point that I didn't make earlier is that asthma is likely underdiagnosed in our patients with nasal polyps. So it is important to ask about lower airway symptoms, including cough or wheeze and shortness of breath. But not only the comorbidities, but there are some interesting studies that suggest, if you look at structured histopathology of the tissue, that if you have higher levels of certain cells or interleukins, this is a controversial area, so I won't go into specifics, but that may indicate that patients might have more aggressive disease. And this is a more local, structured histopathologic evaluation. Katie, what are your thoughts about that? You have a lot of experience working basic to translational science as well. Are there particular tissue markers that are your favorites to look at for recurrence, or you think that are important?
Yeah, that's a great question. So we, in addition to the clinical predictors that we went through in this module and you talked about, we do more in a research setting, like to measure patients' nasal IgE levels. So the polyp tissue IgE levels have found in multiple studies done in different continents, showing that nasal tissue IgE levels are predictive of recurrence, and that patients with very high IgE levels are much more likely to recur. In addition to the work that's been done showing that markers such as interleukin-5 and tissue eosinophils are also associated with recurrence. Right now, these markers are not always widely available outside of research settings. So, certainly tissue eosinophilia is something that is really available for everybody and can be helpful to look at.
Thank you so much. One quick question. Do you have a cutoff of what you think is important, number of EOs per high power field?
For the nasal polyp tissue,
Yeah.
I don't. I mean, I know that, studies showing, more than 10 or 15 is likely suggestive. But I think seeing, when you see a lot of nasal tissue eosinophils, that is certainly informative and can be predictive in that setting.
Great. Thank you to Dr. Buchheit. Thanks to our audience for the great questions. I would also like to thank Regeneron Pharmaceuticals and Sanofi for their support of this important educational activity. Please remember to complete the post-test at the end of the session to secure your CME credits. And please visit immunologylive.com and resinsightslive.com to view today's session, along with other sessions on demand. Stay tuned for the next session titled Inflammatory Pathways Involved in Nasal Polyp Formation Beyond Local Inflammation. My name is Dr. Stella Lee. Thank you so much for joining us.